Welcome to Hernia Talk Tuesdays. We are live. My name is Dr. Sheen, as most of you know. I'm a hernia and laparoscopic surgery specialist, and I love what I do. And today's guest panelist who will be sharing the hour with me is Dr. Aali Sheen. He practices in Manchester, United Kingdom. I should be calling you Professor Aali Sheen. That's the European way. You can follow him on Twitter at Aali Sheen. And without further ado, welcome Dr. Sheen, or Professor Sheen, I should say.
Yes, that's very kind of you. Yes, unfortunately, I do have a chair and I am called Professor, but Aali's absolutely fine. And thank you for the invitation, Shireen.
But I'm told actually in the UK, it's not appropriate to say doctor. You should say professor, because is that true?
Well, actually, it is doctor for everyone, but then once you become a fellow of the Royal College of Surgeons, you become Mr. We go back to
Mr.
Yeah, we go back to being barbers because we were the company of barber surgeons.
Yes.
Then we became the company of barbers and company of surgeons, and then we got a royal charter, and then that was it really. So
so I should have called you Mr. Sheen. That's so weird for us Americans.
No. Professor's fine.
Yeah. Okay. So as you all already heard from my quick introduction, Mr. Professor Dr. Sheen works in the United Kingdom. He's a friend of mine. We've met through the Hernia Society world. He's been a lovely partner for patients who reach out to me and need help in the United Kingdom, because he's among very few surgeons that not only specializes in hernias, but also sees some of the more complicated hernias, deals with groin pain, and very specifically, you have formed a very well-known niche in the sportsman's hernias. And that is kind of a misnomer. They're usually not hernias, but they are typically in sportsmen or sportswomen or sports-related, athletic-related. Some people call it athletic pubalgia. It can be some type of disruption of the pelvic floor or the abdominal wall. So I really want to spend as much time as possible on that part of your practice. But before we do that, I want you to do two things. One is, you shared me before we started. You shared with me the two books that your two favorite books right now. You want to tell the audience what you have right now.
Okay, right. I'll get one of them. It's by Bill Bryson, who's an American who lives in the UK. It's called The Body. It's called A Guide to Occupants. It's a very good read. If you're a clinician, I think you'll enjoy it. And the other book, which is a fantastic read, it's by Shireen. It's on chronic pain.
Yes.
The Sage's Manual Guide, which is an absolutely brilliant read. And if there are any physicians or physios or healthcare professionals that are logging in, I'd thoroughly recommend you read this book, especially if you're thinking about managing patients with chronic pain. It is a brilliant guide.
Thank you very much for that. Okay, so can you describe a little bit of your practice? In the US, we usually are either employed or we have our own private practice or some kind of hybrid of that sort. But in the United Kingdom, you have the national healthcare system, the NHS, and you are an employee of the NHS, so people can get care from you there. And you also have your own private practice. And what's the name of the clinic that you work out of?
Manchester General Surgery.
And that's where you do a lot of your athletes. I understand there at Manchester may have a soccer team. I've heard of them maybe before.
Yes.
You want to describe a little bit of kind of what you do in that realm?
Sure. Well, in the UK, we have the National Health Service, which is free healthcare for absolutely every person. You don't pay a penny, and every single doctor is trained by the National Health Service, and they practice in the National Health Service. Now, when you fully train or become a consultant, then you have the right to do private practice because you are a fully trained individual. You can work independently. And until that time, you remain in the National Health Service. Okay. Now, whether you wish to do private practice is up to you. Some consultants don't wish to do any. So you don't have to.
Mm-hmm.
The further south you go in our country, i.e. London and the southeast, which is slightly more affluent, then the more private work there is available. So you have to just divide your time and work that way, and that's what we do.
And what's your connection with the soccer world?
I see a lot of patients, and it usually comes through reputation. Someone with who's been around a long time, seeing a few footballers. So I look after anything between 20 and 50 clubs, including rugby league, rugby union, football, soccer. I see jiu-jitsu, British Taekwondo, British Olympics come to me, and a lot of high-profile athletes end up in my clinic.
Yeah.
There's a few of us that do this sort of surgery, and we all try and work out whether they've got a groin which needs repairing or not. And I hopefully don't need to repair most of their groins,
Yes.
which I can talk about if that question arises.
Yeah, we'll get to that shortly. And then lastly, just to get a grip of things, as you know, the healthcare system has been hit with this COVID pandemic worldwide. In the United States, we were on lockdown for providing any elective healthcare. So I was not operating for about just under 2 months. And then slowly our hospital opened back up. The purpose was to focus the resources on the very sick patients and also not to expose healthy patients to this subset of sick patients that are infected with the novel coronavirus. In the US, most hospitals have opened back up to elective care. There are some that are limiting it and prioritizing it, but for the most part, if you need a hernia repair, you should be able to find a hospital or clinic or surgery center that can provide you that elective repair. But I understand right now that's not the case in the Great Britain or United Kingdom. Is that right?
Yes, I think unfortunately there are problems. I mean, we were shut down from March, April, May through to June for all benign, non-emergency, for all benign, non-emergency and elective surgery. There was a complete shutdown.
Okay.
So cancer surgery continued, emergency surgery continued.
Mm-hmm.
Now we are slightly opening up. So the orthopedic surgeons are undertaking hip, knee surgery and so on. But overall, the hernia surgery is slowly coming back. We
Okay.
are calling patients, making sure that they're still fit and able. But the specification specifically for surgery is you have to isolate for 2 weeks and you have a COVID test 48 hours before the operation. And that's for every single patient right now.
Got it. Got it. Yeah, and that's unfortunate. And you told me you have a very, very long waiting list for your elective patients on the NHS side.
I do. I have over 100 patients
And
waiting.
that's just you. You alone have over
That's
100
just
patients.
me for
Oh
hernia.
my God.
Yeah, I know.
Wow.
I know.
And that includes chronic pain. What if they're in chronic pain?
Yes, it does. And I'm slowly trying to do some patients now, but very slowly. I mean, I think, we have to just persist with painkillers, injections if we can,
Oh,
and those
yeah.
sorts of things.
I know you've been sharing a patient that needed injections at the very least, and you've been helping me get that patient to get their injections because you couldn't offer surgery in the
Yeah.
system to them. And even getting the injections was difficult because that also was not offered as an outpatient in a lot of places because of the restrictions. So we're
Yeah,
hoping that all of our countries become safer so we can provide more elective care.
absolutely.
Okay, I would love to talk about the sportsman, but we already have a lot of questions live. So just briefly, you have one patient which asking if you can help her. She has incisional hernias. You do operate on incisional hernias, correct?
I do, yes.
Okay, perfect. Um, another one, well, okay, so these are really big hernias. This lady, she had bowel, intestinal cancer, probably colon cancer back in 2014 and had an incisional hernia. She had a colostomy at one point. Um, and then it seems that she was told to wear a binder for a while. She did have a hernia repair and then looks like she recurred. Are these operations that you would do like a recurrent hernia repair? And then what do you offer? Open, laparoscopic? You have the Versius robot now.
Yeah, I mean, I think you see now the most important thing about the hernia repair is obviously I think it's good she's got through her cancer surgery and the colostomy I believe has been reversed.
Yeah.
The abdominal wall has already been operated on a couple of times. The new tissue is always weaker. Now, I would look at the patient. I want to undertake a scan to see how big the hernia is. I'd want to know exactly what operation was undertaken,
Right.
where the mesh was placed. Was it placed like an onlay, or was it placed between the rectus, which I think probably it was, or was it an inlay mesh? So basically like a laparoscopic IPOM repair,
Yeah.
where mesh goes inside the abdomen.
Yeah.
I'd want to know. And then I'd decide on what I would do. Now, if the hernia is under 6 centimeters for me, and it was a previous open repair, I would try a laparoscopic repair.
Yeah.
If the hernia is larger and it was a previous laparoscopic repair, I would try an open repair. Generally, I'd go to, whether it's open or lap, I'll go to the other one for a recurrent hernia. But you probably will need more mesh. And I know mesh is a bit of a word which can cause patients to frown, but I will definitely put in another mesh, and the type of mesh would depend upon the size of the hernia, the location, and obviously the tissue integrity. Now, as for yourself, if your BMI, your body mass index, is greater than 35, I would definitely over 40, I would encourage you to lose weight. I don't know
Any
what your
obesity
BMI.
should be treated. Absolutely.
Absolutely. And also, if you're a smoker, you would need to stop smoking.
Yeah, because the nicotine and the smoking itself can prevent healing, and it's been shown to increase your recurrence rate, I think by 7x.
Yeah.
That's a huge number.
It's
Where you're just not healing, and so you're not getting oxygen to your tissues, and there are other ways that the tissue changes, and you have hernia recurrence. So smoking is a big deal. In California, most people don't smoke, so it's not as big of an option problem in my state, unless I get people from out of state. But Europe, people like smoking all the time.
Yeah. I mean, we've got quite a high tax. I think what's helped in the UK, actually in Europe, I suppose we're technically still part of Europe. I think what's helped is the smoking ban in public places. That's helped.
Okay, yeah.
So restaurants, pubs, we can't really smoke in any of those places now. So
Yeah.
it's helped a lot.
And if this patient's worried about strangulation, what do you say to people with really large hernias that have recurred about strangulation? Should they be more worried about, I would say I'd be more worried about, the outcome of the operation
Yeah.
and to optimize that. Whereas strangulation for big hernias is not as big of a problem as some of the smaller hernias or the more symptomatic hernias.
Yeah, big hernias, I wouldn't worry about strangulation. And what you do worry about, sometimes if you see your overlying skin and becomes red and angry, it means there's bowel just directly below it and it's very unhappy. So
Yeah.
that's the thing we worry about. But actually strangulation it's more common in the smaller hernias or the smaller
Yeah.
defect. If you just pop through a loop of bowel, if you cough, and then it won't pop back.
That's correct. All right, let's move to what is your specialty, which is the sportsman's hernia. So what is your definition of a sportsman's hernia?
This is a good question. Now, I'm gonna say a sports hernia is a misnomer really, and there was two key publications, one in 2014 which came out from Manchester and one in 2015 which came out from Doha. And what they're basically describing is, first of all, the Manchester one said it is really a disruption of the inguinal canal, i.e. the inguinal canal isn't as strong as it should be, and that's what it is. Why was it called a sports hernia? Is because a repetitive strain injury. It was mainly athletes that were undertaking this activities, mainly athletes that were presenting to surgeons with pain in the groin. And that was the main problem. So it's called a sports hernia, but it isn't actually a true hernia. You could call it an incipient hernia or an
Yeah.
almost an hernia. Now, if I'm allowed to share screen, if
Yeah,
you
please
stop
do.
sharing, then if you need to stop, and then I'll share.
Oh, sorry.
Yeah, that's fine.
Go ahead.
I share, and I'll show you the picture. I hope you can all see that. That's from the Doha statement, and that was 2015. So in 2014, they said it was inguinal disruption, but Doha went a little bit further, where they said a groin pain is really divided into 4 categories. It can be related to the adductor tendons, so adductor related groin pain. It can
And
be
that's the
due to
muscle
psoas.
that moves your leg inwards.
That's right. Yeah, brings both your legs in.
Uh-huh.
So sometimes you can actually test that on yourself. If you put your fist between your knees and squeeze tight, if that hurts, it means my adductor's not happy.
Okay.
Okay, so then you've got the psoas muscle at the back, and that's the one that brings your leg up.
Like hip flexion.
Absolutely. So it brings your hip up, brings it up. And in order to know if you've got tenderness there, if you lie flat on a table and with your hips almost at the end of a bed or a table, and then if you try and lift your leg, your thigh upwards with resistance, that's a psoas problem, or psoas tendinopathy we call.
Yeah.
Obviously, I've just described inguinal related pain, and then there's pubic, so like you get pain around the pubic bone. So when patients come to me,
Great
we
picture.
usually elite athletes, absolutely. What I do is I rule out the green, make sure there's no iliopsoas pain. I rule out the blue, make sure there's no pain from the adductor.
Yeah.
Make sure there's no pain from the 6-pack muscle, which we all proudly display every day. And also there's no pain from the pubic bone. And then if there's no pain from anywhere around these, and I feel that after an ultrasound examination, there is a bulge or a weakness in the inguinal canal,
Yeah.
then I'll offer them a repair. And basically that's what I do. So the question then arises is that how do I repair it? And what I always say to surgeons is that repair it the same way you would repair any groin. So if you wish to
Really?
do keyhole, then you can repair it by a keyhole technique. If you repair it either technique or an open technique, you can repair it. Now, some surgeons choose to use mesh, others use a suture just on the back wall. But what you've got to do is you've got to do slightly, I say, a more widespread repair. Now, if I do it by keyhole technique, I make sure the pubic bone, I go way below that without injuring the bladder. And I make sure I go as far across laterally to the side without obviously going into the abdomen.
Yeah.
Make sure the mesh is higher. So the mesh I use is bigger for these.
Okay.
And they do very well. But what's interesting is that in the canal you may find just a fatty lump, a lipoma. And something as simple as that can be causing the pain in the groin. Why? Because you're overusing your groin so much. The lump is irritating your groin. It's going in and out, in and out. And it can be something as simple as that. But 24 to 30% of my patients will have an adductor injury. That's the muscle that brings your legs in.
Yes.
Okay. And about 5% will have a pubic bone injury, or what we call inflammation around the pubic bone. Now, by and large, most of that doesn't need any treatment. So after I do any sort of repair, I encourage a rehabilitation program. And what this
Yes.
involves is complete rest for 4 days. And then I get the patients up, and then I get them to get on a cross trainer. And a cross trainer, you're just moving your arms back and forth, and you're using your legs up and down. And that really just allows you to start moving your core. Everyone talks about the core, and you need to really improve your core. Then a few days later, I get them to start doing plank positions, arm raises on plank, improving their core. And then after the first week, I'd start the adductor rehabilitation. Now you can just have a towel on the floor. You can put one hand, and then you can put both feet on the towel and just move your foot in. Make sure the floor is a bit slippery. Don't try it on carpet because it won't work.
Yeah.
Move your leg in, and then do the other side, and really get your adductors working. So core strengthening, adductor strengthening is very, very important. Now that will go on for about 2 weeks. And then after 2 weeks, you should really start upping it. So you can start some physical exercises. You can start some light jogging. A lot of sports hernias or inguinal disruption patients are keen runners, the keen soccer players, they're
Yeah.
keen rugby. I very, very rarely see cyclists and swimmers. And knowing this fact, the other rehab I do is I tell patients, some people can't swim, which is absolutely fine. You can go to the shallow end, go up to waist height,
Mm-hmm.
just walk up and down the pool, walk up and
Okay.
down in width. And that really gets your groin going and really gets your core moving as well. And the other thing is cycling. Now, if you can't ride a bike, you can sit on a bike that doesn't move, an exercise bike. So you can cycle.
Stationary bike, yes.
And I don't know about Shireen, in your experience dealing with these kind of patients, but I very rarely see cyclists because cycling
Correct.
is fantastic rehab for the groin. It is absolutely brilliant. I saw one cyclist years ago, and I think he just wanted to get out of an event. So I said, fine, you've got groin pain. So he could then tell his sports doc, look, I'm not cycling today.
Mm-hmm.
And I've seen one boxer. And again, I think he just didn't want to fight with the person that he was supposed to fight with. But boxing, it's all upper body, all strength. And they've got really big, heavily built, muscles and six packs and cores. If anything, they're more likely to get umbilical and epigastric pain. But boxers I don't see, cyclists I don't see, and swimmers I don't see. So getting your fitness back, all of their sports are good sports to actually undertake to get your fitness back if you've got a
Correct.
sport hernia.
Yeah, it's usually soccer players, NHL, hockey players.
Yeah.
Sometimes baseball, sometimes um, tennis,
Yeah.
but yeah, maybe some basketball, but it has to do with kind of the thigh and the going in the wrong direction, and also the mismatch of the muscles, some muscles being too strong without balancing the counter muscle, which is why physical therapy is so important, is they're the ones that are doing that.
Yeah. It's the
Yeah.
twisting and turning motions.
Okay, so I understand the whole thought of, okay, if you see a little piece of fat, like I just call those hernias. I don't call those sportsman's hernias. If it's groin related with a herniation of something, I just call that a hernia. But when
Mhm.
you have a tear of the adductor muscle, a tear in the external oblique aponeurosis, a tear in the adductor, uh, where does where do you fall? Do you release it? Do you sew it back on? Do you add mesh? You don't add mesh? What are your thoughts? And then, well, by the way, just for everyone, when we say mesh, there's a million different types of mesh. There's synthetic mesh, biologic mesh, hybrid mesh. There's a wide variety. So we're going to talk a little bit more about mesh later because I'm getting a lot of comments on the Facebook side. Um, but just so you know that just because we're saying mesh, it doesn't mean we're causing some like destruction of the body necessarily.
Yeah.
So we'll discuss that later because that's a very important topic for
Yeah.
me as well. But just
Adductor injuries. Yeah.
yeah. So do you use mesh if you have a rectus or adductor injury or
Yeah.
not? And
So
then do you release? Do you reattach? What is the thought process of that?
sure. So adductor injuries generally present with heavy bruising down the thigh. You get a huge
Okay.
amount of bruising. It's very painful. They usually feel a snap. They may be kicked a ball, and it's excruciatingly painful. Sometimes they can't even walk. Now, the first things first, you need a magnetic scan. And the magnetic scan, an MRI, which you're an expert on, Shireen, and will
Mhm.
show whether you've got an adductor injury or not. Now, if it's say 3 to 5 centimeters, you could ride it out. But if it's like 5 centimeters complete disruption, you could think about reimplanting it. And that will just be a simple, a non-absorbable suture, and you can reimplant it back on. Or you can just leave it to heal by secondary intention. Because if you think about it, that player or that person has actually undertaken their own tenotomy. They've actually
Yes.
divided them to themselves.
Yes.
So maybe the adductor was too tight. So they've undertaken their own tenotomy. And if it
Correct.
just heals with fibrous tissue, in 2 or 3 months' time, you'll find they actually feel better. Now, how many adductor tenotomies have I done? If I see 100 patients with groin pain, I may undertake one. I think
Correct.
it's an operation that is undertaken a little bit too much. I think I've seen a number of patients over the years that have undergone adductor tenotomy and they're actually not better. So
Yeah.
why aren't they better? It's because they probably didn't need the adductor tenotomy. Now, when you feel the adductor, when we feel the adductor tendon, it feels really tight and it feels like you can pluck it. And if the other side's nice and smooth, then you can work on that adductor. You can
Hmm.
work on it with physio, massage therapy, and also shockwave. I'm a big believer in shockwave. And then you can also
Okay.
do dry needling. Now, dry needling is where you just put needles in it and you make it bleed. You make it
Mm.
bleed, it'll get bruised, it'll be very sore. But what has blood got in it? Blood has got all those healthy,
Factors.
healing
Yeah.
cells, the white cells, the fibroblasts, collagen. It's got fantastic healing. The next approach after massage, shockwave, and dry needling will be PRP injections. And that's taking your own blood, spin it in a centrifuge, you take the plasma, you mix it with some other constituents, and then you inject it back into the adductor. And
Right.
you do 3 injections, maybe over a year, see if that helps. And generally, you find it does help some patients. Um, if they're really stubborn and it's tight, it's not getting better, then I may consider a tenotomy.
Got it.
But I would compare it to the other side. If the other side is the same, I'd say, look, why don't we just see how it goes? I don't think your adductor's ever going to get better.
Yeah.
They eventually do get better. If you can tie your shoelace without pain, I will
Mm.
discharge you. That's a very good sign for adductors.
And when you get an MRI, does it always show the problem? And what you see on MRI, does that correlate with the severity of the injury?
Yeah. Now, when you see some MRI reports, you can decide where the MSK radiologist is trained,
Yeah.
because across the pond in your neck of the woods, you use the term athletic pubalgia quite a
Yeah.
lot. Okay, and that is a conglomeration, sort of like of all the findings. So if you have an adductor tenotomy or adductor tendinopathy, if you've got a rectus adductor aponeurotic plate tear, if you've got a tear in the pyramidalis muscle, or if you got a bruising of the or osteitis pubis, then a radiologist may say there are signs of athletic pubalgia, and I'd accept that. That's absolutely fine. But each one of those needs a different treatment.
Yes.
You see, the adductor tendinopathy needs rehabilitation. It needs physio. It needs rehab. It needs shockwave, possible dry needling, possibly PRP. A rectus adductor tear, aponeurotic tear, is purely conservative management. You leave it alone. You do not do anything. It will get better. You
Yeah.
can try a local anesthetic injection, just local, into the area. You may get some pain and tingling with the injection, but if your pain resolves after that injection, and it will resolve for about a day or two, then that's the diagnostic. These are diagnostic injections. If that doesn't resolve it, I'll put some local into the adductor tendon and say, go away for a day, come back. They come back and they say, right, I still have pain. I said, fine. Then I will inject into the inguinal canal with local anesthetic. I'll get my radiologist to do all my injections under ultrasound guidance. And then if the pain goes, I say, fine, I'll repair your inguinal canal. And I can
Yeah.
do that whichever way I wish. And
Yeah.
that's a diagnostic way of determining the cause. But it's an umbrella-like term. An MRI scan can say, yes, this is a sportsman's hernia because it has one of those 4 findings which I've
Got it. Got it.
mentioned.
Got it. Got it. You have coined the term Manchester groin repair. Can you
Yeah.
explain what that means or
Well,
how it's different or why
I
is it
mean,
so special?
it's very special because I created it.
Yes.
I've said it's slightly different from a TEP repair, and my colleagues would say that's a very academic fudge. And I said probably I wouldn't disagree with you entirely,
Yeah.
but we're very
Yeah.
polite as Brits. We never really point fingers at each other.
So it's a
So
laparoscopic repair.
that's right. What this repair involves is the TEP, the TEP, so extraperitoneal, and it's basically what I've described is my dissection, because I have a recurrence rate of like less than 1% and a chronic pain rate of 0.3. So I use a bigger mesh. Most operations with the TEP, and we did a review of all the repairs, and everyone described a 15 by 10 mesh. I use a 15 by 12 or sometimes a 15 by 13. So I use a bigger mesh. In a slightly small built person, I'll use a 15 by 10 because that is a big
Mm-hmm.
mesh for them.
Yeah.
I use tissue glue fixation, and I insist on fixating at least 3 centimeters below the obturator fascia. And that's different to what everyone else has described. And
Mm-hmm.
I always fixate laterally and inferiorly. Superiorly, I don't think you need to fixate. But if you do, if you've got a little bit of glue left over, then that's fine. Now, in choice of glue is entirely up to you. There's 2 brands that people use, is the Tisseal or Tissue Coal, which is a product by one company. The reason I use that glue is because it is absorbed in 7 days, it completely disappears. And so there is no focus of infection. The other one is cyanoacrylate glue. I think it's a little bit more toxic. I think it sticks very well, but I don't use it because I think it's a focus of infection and it will
Yeah.
remain. So I choose not to use that glue. But that's all the Manchester groin repair is. I've done, I mean, I don't know, ballpark 2,000 hernia repairs in 15 years, probably a few more. I don't know, plus minus 2.
Yes, exactly.
Um,
Well, I think the
yeah,
key is surgical technique makes a big
yeah.
difference. I do hernia repairs. I do them with mesh, without mesh, and I see people that have chronic pain and complications, recurrences, different types of pain injuries with mesh and without mesh. Um, the problem I think that we see with so many mesh-related complications is, at least in the United States, almost all hernia repairs are done with mesh. Now, there are people that react to mesh, and that's a totally different situation. Those are people that can't have mesh. But everyone else who has a mesh-related complication, I would venture to say at least half of them, if not more, it's not the mesh, it's the surgical technique.
Mm,
So too small of a mesh, inappropriate use of the mesh, inappropriate placement, poor dissection, too aggressive of a dissection, all of those, the decision making, the technique of the surgeon, their experience, all that matters. So when you're saying that you're doing a much wider dissection and very careful placement of the repair, and you're using a glue, and you have a less than 1% recurrence and 0.3% chronic pain rate, that's vastly different than the average hernia repair. But also, the average hernia repair is done by surgeons that aren't necessarily specialists. So it's
mm.
like having your hair cut by someone who's a specialist versus like me. You don't want your hair cut by me. I've done it myself once. It was a disaster. So I mean, I can learn, but that's not the point. So I just want to alleviate a little bit of that discussion, which is there's so much negative backlash on mesh, rightfully so, because many people have been hurt by it. We don't hear as much from the patients that have been helped by it, which are a lot of our patients. But I would like to talk about that because the UK is actually a country. I would say UK, Australia, United States, the 3 most vocal group of patient advocates um, trying to fight against patients being harmed by mesh live in these 3 countries. And so do you even offer mesh removal? Is that something that you see and have to do among your patients, or what is that
Yes,
part of
I
your
mean,
practice?
yeah, I mean, I've got my secretary from my private practice was saying, "Oh, well, you've got 4 new patients next week in London." I said, "Oh, what do they want?" And they said they're all mesh removals.
Yeah.
They all have chronic pain. And I think your summary of mesh and its problems was very good, Shireen. Uh, and in the UK and in Europe, you know, and I was speaking in Bucharest from the same place here, you know, my house, um,
Yes.
earlier this week. And basically, the commonest hernia repair undertaken in the UK and in Romania, and I don't know, you could correct me for the United States, was the Liechtenstein repair. That was the
Yes.
commonest, as an open mesh.
We're
That was
talking inguinal hernias. Yes.
Yeah, inguinal, that is the commonest repair undertaken. So over 60% in the UK are undertaken. And by and large, the majority of these patients do not have a problem with mesh. Now, my question is, Shireen, I have never seen an allergic reaction from mesh placement, a systemic inflammatory response from mesh placement in any patient. I have never seen it, and I've never heard of it. So I don't
Well,
know what your experience is.
yeah, I do see it, and we've done a
Right.
whole segment on it with a specialist who has been able to help in the science behind it. But there
Mhm.
is something called Asia syndrome, Schoenfeld syndrome, mesh implant illness, mesh
Yeah.
reaction, where a subset of patients actually, the same way that they can react to dental implants or breast implants or other implants,
Okay.
they will have a systemic reaction. That one, that if you have a systemic reaction to mesh, either never get mesh, and what I by mesh I mean synthetic
Mhm.
mesh, or if you have it in you, that must be removed. That's the only treatment for it.
Sure. Sure.
But it's uncommon. Fortunately, it's a
Right.
rare problem. It's like being allergic to certain type of food. Not everyone is allergic to a certain type of food, but if
Yeah.
you are, like peanuts, then you shouldn't be eating peanuts. So,
Yeah.
and sometimes you don't know until you eat that peanut. So unfortunately, we don't have any tests that measure mesh reaction, and we don't have any foolproof product implant. It's an implant illness. So any implant theoretically you can have a reaction to, even biologic mesh, even cow, human, cadaver. I've seen people that react to that. So um, we don't have a science behind it yet to determine who is
Okay.
that. But it's a
Well,
rare, of all the people that have mesh problems, that is the smallest
yeah.
group, fortunately.
Well, I think the audience need to know that mesh, um, the furore in the UK really came about from a TVT repair, which is a vaginal prolapse repair.
Yes.
And obviously, the mesh has eroded a very sensitive part of female anatomy, and I think they did suffer with pain. But we had a number of patients that were very vocal, but there are thousands of patients that actually did very well from the
Yeah.
repair, and they didn't have a problem. Now, just like you're having a heart valve replaced, you're having a knee replacement or a shoulder replacement, they use metal or synthetic material. So mesh is our scaffold, that is our synthetic material, that is our
Right.
prosthesis. And this is what I say to patients. Can it get infected? Yes. Can it cause pain? Yes. Can it cause nerve damage? Yes. Sometimes does it need to be removed? Yes. What are the incidences? Very rare. That's what
Does
I
the
say to all
UK
my
have a
patients.
registry? Because in the United
We
States, we kind of do, but we don't really.
Well, our registry will hopefully be up and running later this year, because in
Mhm.
November, the president of the British Hernia Society, Liam Horgan, has done a fantastic job, and on November the 3rd, I take over. So it's actually one day before your election. So I take over. I become the president of the British Hernia Society, and I'll have
Yeah,
only a 2-year term, and
yeah,
there's no debates at the end of it. So my job will be to get it going, to get it up and running. And I think that will be key. But from the evidence from the Danish hernia registry,
yeah,
I think there's evidence to say that yes, mesh can cause pain and mesh explantation is required, but it's rare. It's rare. There's
yeah.
over 100,000 hernia surgery reported on that registry. So I don't think, I think the mesh problem is there, but we need to alleviate it, and we need to tell people, look, it can cause you problems, but we never know if it is the exact cause. Now, my chronic pain patients, now you see a lot more chronic pain patients than I do,
Yeah,
Shrik.
I do.
And what I say to them, the last line in my letter is, there's no guarantee of success. The mesh may not be the cause of your pain. And like you, I do a lot of tests before I operate on them and explant the mesh. I do injection therapy. I try a TENS machine. I try nerve painkillers and see if these help. And if they don't, then the last resort is an operation, which involves mesh removal and nerve division. But again, some actually do get better, but some just say, I'm a bit better. And if they're 50% better, I usually say, that's fine. I'll take that.
Yeah, I
So
think
that,
yeah. So there's a lady who is on this, who may have to come see you, sounds like she has a meschoma. So the mesh is balled up, and that's preventing her to do things like sit and bend and cross her legs and so on. So hopefully she can reach out to you. But during the pandemic, both on the NHS side and the private side, are you available to take out mesh if it's needed? Is that
Oh yeah,
surgery available?
yeah. I do it. I do it, and I take out abdominal mesh as well when it's needed.
Okay.
But I do it carefully. I do it with good consent and the patient's knowledge as to why I'm doing this.
Yeah.
You know, is to get them better. Mesh isn't always the source of the problem. I do write to a lot of my colleagues and ask, literally politely demand the op note. I
Yeah,
need to see
absolutely.
their op note.
Mm-hmm.
I need to know what's happened, what's been put in, where it's happened, you know, and you know, all my colleagues have done a really good job and they're all very experienced. But I think that's where, you know, this book of course comes in. It's very handy. I read that a few years ago and it shows you how to manage them. I think nerve mapping is very important because if I was to communicate a chronic pain patient to you, and I use Shirin to all the audience, you know, if there's a difficult patient I do email her securely the
Yeah,
details to
we
try and
share.
find out,
We
you
have
know, what
a
else can I
group.
do here?
We have our group of hernia surgeons all across the world that we do share and take care of that. One issue that I'd like to mention is that so the patients who are hurt by mesh obviously want us to do more. I think we're trying. We can do more. The registry is a good way to do it. The Danish registry, Swedish registry, they're the strongest, and their numbers don't really reflect the needs of the patients. And when I say it's rare, you know, I think there's one paper by the Danish registry that showed abdominal patients that needed abdominal surgery again after abdominal wall hernia repairs over a span of, I think, 20 or 30 years was just under 10%. Um, and those are not necessarily hernia mesh problems, but that's just any surgery related to the hernia repair. That's the largest number we have to work on. And for groins, from what we understand, again, our data is flawed because we don't have the registry. Mesh reactions are a fraction of a percent, and mesh complications are in the 10 to 12%. So mesh complications are not rare, but mesh reactions, as far as we know, are rare. So until we have a better system and until we have patients groups that can work with surgeons to look at these numbers and publish it, I can say something and you can say something and a patient who's suffering can say something and we may not all agree. But that's just the experience that we have. And almost everything I do is based on chronic pain and mesh related complications. And I'll tell you, I read the op report and I can tell you exactly what the complication is based on the op report. I'll read it and be like, oh, they used the wrong size mesh. They did the wrong technique. They forgot to do X, Y, and Z. I can't believe they used this suture. And my nurse comes in after seeing the patient, and I know exactly what's wrong before I even heard from her because I read the op report and I could predict what was wrong. So surgical technique is very important.
Can I just
Yeah.
say, Shirin, the science, we've just closed our randomized controlled trial TACO-MESH, which is intraperitoneal mesh comparison of two TACOs or non-TACOs. And we've had to close it because of COVID, but we've also got a blood arm. So from 25 patients, we've taken blood preoperatively and blood on day 1, day 3, day 7, day 30, and 1 year. And we're looking at 25 different inflammatory markers. My research fellow James is doing all of the ELISAs every evening. He's working hard in the lab, and so hopefully in a year we'll have some results to see if there is an inflammatory response from the use of mesh. And it is a the most invasive use of mesh. It's an intraperitoneal mesh.
Yes.
So let's see what that shows.
Yeah, we just need more data to be able
Yeah.
to discuss this better. The other issue is, I think, the overuse of mesh. You offer tissue repairs for like groin hernias, especially probably the patients that have sports injuries. Many of them need tissue type repairs. Most surgeons, at least in the United States, do not offer tissue repairs. That's an issue. And they also necessarily don't see their patients once the complication occurs, either patients don't grow them, whatever. So there are surgeons out there that are not aware of the problems, and also surgeons that are not able to fix the problem. So it's incumbent on the patient to kind of find their own specialist, which adds to the frustration, I think, because your local surgeon may not be able to handle the complication, which is true for any operation. Any operation where you have a complication, the skill set for a complication after hernia repair or any operation is very different than the skill set to actually do the operation. So until we have a critical number of surgeons, and I train every single year. I train surgeons and put them out there, and they go to their different places. I have one in Georgia, I have one in Michigan, where now they can offer those services because they've trained under me. But like I'm like one person. We have only a handful of people in the United States that do what I do. I just want to kind of put that out there. I have a question that was asked of you about your tissue repair. So there are a variety of tissue repairs. There's a Schuldeis repair, there's a Moshawek repair, there's your type of repair. They all involve cutting the genital nerve. That's how it's originally described. Is that something that is necessary? What's your thought on that? And what do you do?
If you read the International Groin Hernia Guidelines 2018, it categorically says you must identify the nerves and not cut them. If you've got a nerve, it's there for a reason. Don't cut it, leave it alone. So at the Sports Institute in London, it was 1v2, it was me versus Ulrika Mushawek and Ernest Shoulders, and they happily divide the nerve. And they claimed, and I think this is wrong, that the nerve was under pressure. It was subjectively compromised. And I said, well, how do you know? What test have you done? What actual test have you done to show that this nerve is under pressure? There's no test.
Yeah.
If you divide the nerve, you get insensate area, medial aspect of thigh, maybe the upper third of the scrotum. And if that's where they're experiencing the pain goes. But when you divide a nerve, it can actually lead to more pain because you've got the proximal part can develop a neuroma and you can develop more pain. So why are you going to divide a nerve? So I would never divide a nerve. I do offer a minimal repair. It's called a minimal repair. And I will offer it in patients aged between 18 and 30, young, fit, male or female that have a small direct or indirect defect.
Yeah.
And they will get a suture repair from me. Now, if you look at chronic pain, what's going to give you chronic pain? A suture repair, mesh, Liechtenstein, or laparoscopic repair. In Stina Oberg's systematic review, which was published in 2019, she said there was no difference. That was a large study looking at lots of papers. She showed no difference, but felt that the chronic pain was far less in the laparoscopic repair, where you have to use mesh. So that's the first thing. The second thing, and this is really important, chronic pain preceded mesh repairs. Now, mesh repairs was invented where you are. Liechtenstein popularized it.
My hospital, actually.
Yeah, exactly. And so now that repair is still the commonest repair undertaken worldwide. Why? Because it is a tried and tested good repair. It is tension free, and all we're doing is using a scaffold. That's it. Do you need antibiotics? No, you don't need antibiotics. All of the research and data shows only if the patient's immunocompromised, steroids, or you're worried, or recurrent repair, then you can give one shot of antibiotics. But why we're not giving antibiotics for the large majority of patients? Because they don't need it. The risk of infection is very small. So it's a straightforward operation. And when you see the nerves, you must identify them. The genital
Absolutely.
branch of the genitofemoral nerve, you have to dig for it to find it. The ilio-inguinal nerve is the commonest nerve which you will see. You may not even see, up to 30% of patients, you may not even see the iliohypogastric nerve.
Right.
So don't go looking for them. And if you find them, preserve them, protect them, don't divide them, do not skeletonize them. So dividing the nerve, I personally think is a mistake. I
Yeah.
disagree with it. I would, you see, is it negligent is the question. I don't know. I don't know. It's a difficult one to answer. However, when you're looking at causation and negligence, you have to decide, would a responsible body of surgical opinion advocate the division of the nerve? So if the International Groin Hernia Guidelines in 2018
Mm-hmm.
are a body of responsible surgeons have said, do not divide the nerve, you
Yeah.
could say dividing the nerve when it is uncompromised is negligent. And I'm putting that out there. And
Yeah,
that's what I,
the Schuldeis clinic routine, well, the way that the original repair was kind of described includes cutting the cremasteric muscle because they feel that improves their outcomes. They looked at their data. If you cut the cremasteric muscle, they get less recurrence, and in so doing, they feel they also have to cut the genital nerve to reduce the risk of adversely injuring it. I don't know why Michelle cuts the genital nerve.
I don't know. The cremasteric muscle, dividing that, I don't particularly object to, unless you're a Canadian moose, which has got such a hyperdeveloped cremasteric muscle to keep its testicles warm in the freezing cold Canadian mountains. You don't really, you'll manage without the cremasteric muscle, so that's fine. But
Yeah.
no, you shouldn't really be dividing the nerve.
Yeah.
I don't agree with it. I wouldn't advocate it, and I wouldn't do it.
So if a patient needs to follow up with you or see you, or if they're on a wait list, how do they kind of contact you? What's the best way to contact you?
Oh, you could just Google me. There's emails, and you can just email my secretary, and you get a reply very quickly. A bit like yourself, Shireen. You know, we're very proactive.
Yes.
And then for overseas, I mean, I do see overseas. I look after a number of clubs in some European countries that I won't name because then my competitors will find out and they'll be on the
Yes.
blower.
Yes.
And why are you sending this surgeon from this country, this player from
Yes.
this country to that surgeon? So I also have seen patients from the United States, and they usually have seen some of you,
Yeah.
and they just, I don't know, I think they just wanted to fly over and see me in London, or maybe have a, but I think, you know, I'm available for Zoom consultations as well. Um, Judging a time difference, I'm happy to speak to patients and discuss what problem they have, because I think Zoom's very good, what problems they have, how they're managing, and who they have also seen. But in Europe, there are a few chronic pain specialists, but in the United States, you've got, you know, you've got lots of very good specialists like yourself. So I usually just send them to yourselves.
I would say of all the countries, US probably has most of the chronic pain
Yeah.
specialists. That's why I get a lot of requests from Europe, because there aren't that many. There's you and maybe a handful of others in the entire continent.
Yeah.
So it's helpful to have someone to rely on, be able to kind of get some feedback on. So that is it. Is there anything else you want to? Well, you will be the president of the European Hernia Society
British,
a couple of
British,
years.
British
British Hernia
hernia.
Society with
Yeah.
EHS too, no?
No. I'm way down the pecking order there.
Okay, fair enough, fair enough. And so I hope to be able to see you in that capacity uh, when you have your meeting, assuming that our pandemic will be over. I'm hoping.
Yes. Thank you very much. There's a question here to me.
Who is that?
It says Dr. Sheen answered this. He has
Uh,
100 to 200 on the wait list on the NHS, but the non-NHS side is easier to enter. Well, unfortunately, it is, and that's that's just the way the world works at the moment, you know.
Yes.
Um, I suppose the richest man in the world will get his hernia repaired the day he wishes to have it, or she wishes to have it repaired. But you know, I would never neglect one patient over another. They all get exactly the same care, but there is a bit of there is a bit more of a waiting list in a social medicine,
Yeah.
and that's an issue with social medicine. But they still get me, and they still get the best care when it comes around to
Yeah.
their.
Less of a problem in the United States because we don't really have socialized medical care. But those that do belong to a government associated
Yeah.
healthcare system, it's hard to find surgeons that can meet their needs and be specialists and give timely care. So that is a problem. Yeah.
So if you have an inguinal hernia and you say you work in your local mailroom and you don't have insurance, how do you get that repaired? Do you just have to save up in the United
So we
States?
have something called the Affordable Care Act. All
Right.
all employers that have a certain number of employees or more must offer health insurance to their
Okay.
employees. So you
Okay.
must have health insurance. Now, how broadly that health insurance covers everything is debatable per state. But like all my employees have health insurance that I pay for. Um, Anyone that has a job pretty much has health insurance unless they have like a part-time job or it's a very small family business where but in general they're supposed to have some type of stipend.
Okay. It's
That was
interesting.
not true up until like, you know, 8 or 10 years ago. That was not true before. So we're slowly moving in your direction. I think people in the United States feel like they should be getting early, efficient healthcare more often than like in Canada and UK, where they're more used to a socialized medicine, understand there's a wait list. Uh, but you know, our care is also more expensive than in those countries. So you do need to provide some customer service at the same time. And just to be clear, um, there's a lot of talk that surgeons are after the money in doing hernia surgery. First of all, hernia surgery doesn't make money compared to cancer surgery, orthopedic surgery. It's that and breast surgery are the two least money-making jobs in surgery. And secondly, we don't get paid any less or any more for using mesh. The fact that we're using mesh because it somehow pays extra or it's a financial decision has never been true. So let's take that out of the picture, and that's misinformation. That's true in socialized medicine, it's true in the United States. And if anything, it costs more to the facility to use mesh because mesh is expensive, which is why most second and third world countries do not use mesh because they can't afford it. And more of the developed countries use mesh because it's more available. So doesn't mean we're always using it correctly. I do believe we are overusing mesh, but to claim that it's a financial decision from the surgeon is completely incorrect. And I stand by that because I live it every day. So on that note, thank you for your time, Dr. Sheen, Professor
Thank
Sheen,
you.
Mr.
Thank
Sheen.
you.
I look forward to seeing you in Manchester
Yes.
as soon as possible. Thank you for everything you do. Appreciate all the patient help you've given my patients. And I do very much thank the partnership that we have in our little hernia world. So it's 8 o'clock, or actually it's 9 p.m. your time. So time for bed.
Yeah.
And thanks for allowing me an hour of your time away from your family and children. This concludes our hernia talk. As you all know, you can follow me on Twitter and Instagram at HerniaDoc. Many of you are following me on my own Facebook page. This is being a simulcast at Dr. Tofi, and sometime later today I will post access to this hour on YouTube so you can share it with everyone else. Hope to see you next week on another Hernia Talk Live. Thank you very much and enjoy your evening.